Welcome everyone to today's journal presentation. I'm Dr. K. Anurag and my moderator is Dr. Prajwal. Today I'll be presenting an article from the Journal of Postgraduate Medicine. Article is titled Correlation of Cumulative ST Elevation with Left Ventricular Ejection Fraction and a 30-day Outcome in Patients with ST Elevation Myocardial Infarction. Introduction. ST elevated MI or STEMI constitutes approximately 25 to 40% of all acute coronary syndromes, the rest being NSTEMI and unstable angina, and it has an in-hospital mortality of up to 5 to 6% and long-term one-year mortality of up to 20%. Various risk stratification tools have been developed, and the early risk stratification tools such as the TIMI risk score and the GRACE score have shown excellent correlation with short-term and long-term mortality. Late risk stratification tools such as measurement of LVEF by echocardiography, stress testing, coronary angiography, and cardiac MRI have also been used. People with persistently depressed LVEF are at a high risk for arrhythmic and non-arrhythmic deaths. STEMI is a medical emergency and can be fatal if not treated appropriately. The most valuable investigation, which is often used as a first line investigation and is widely available, is a ECG. A standard 12 lead ECG is to be obtained within 10 minutes of presentation of the patient to the casualty. In most developing countries, investigations such as echo and cardiac MRI are not readily available in all centers managing a STEMI. Hence, it is necessary that there's a system to prognosticate patients with STEMI based on ECG changes. Risk stratification is possible by various scoring systems such as the Sylvester score. This is the Sylvester scoring system, and as you can see, it includes multiple criteria and can be quite cumbersome to calculate in an emergency setting. Hence, this is not practical for routine clinical use. So the main aim of this study is to calculate the sum of ST elevation in millimeters in the ECG and assess its correlation with LVEF at discharge and with the 30-day outcome. ST elevation is readily reproducible at bedside and it can help in prognostication of patients presenting with STEMI in hospitals where echo for assessment of LVEF is not readily available. Subjects and methods. The study design. This is a prospective cohort study conducted in a tertiary care referral hospital in South India. Patients with a diagnosis of STEMI as per the third universal definition of MI by ACC/AHA 2012 were assessed. The inclusion criteria. Patients who are 18 years or above were included in the study who presented with within 24 hours from the onset of the index pain, and those who have given a written valid consent and are willing to undergo reperfusion therapy. Exclusion criteria: patients who have overt contraindication for thrombolytic therapy, patients not willing for angioplasty, patients presenting late, that is beyond 24 hours, or those who have an unclear window period, patients who already received thrombolytic therapy prior to the referral to this center, patients who have been resuscitated post cardiac arrest, and those with a baseline LBBB on ECG were all excluded. Methodology. At admission, all patients underwent a 12-lead standard ECG and routine blood investigations as per the institutional protocol. All patients were offered primary angioplasty as the preferred mode of revascularization, and those who were not willing for the same were offered thrombolysis. All patients underwent a repeat ECG 90 minutes after revascularization to assess the response to therapy and to calculate one of the parameter, that is a ST resolution percentage. Patients also underwent an echo prior to discharge and LVEF was assessed. All patients were advised a clinical follow-up after 30 days and on an OP basis or earlier if they are symptomatic. The study variables, ECG analysis. So a 12-lead standard ECG is done for all patients, and those who had an inferior MI, additional posterior leads, that's V7 to V9, were also recorded. These ECGs were then scanned and saved as a PDF, and they were zoomed to 4 times their original size on a computer screen and analyzed using calipers. ST elevations were measured nearest to the nearest 0.5 millimeter mark at the J point based on the third universal definition of MI, and the residual ST elevation was measured in a repeat ECG 90 minutes after reperfusion to calculate the percentage of ST resolution. Echocardiographic assessment, left ventricular ejection fraction was measured using biplane Simpson's method and Thicoult's method. The clinical endpoints, the duration of the stay, reinfarction, congestive cardiac failure, and death were all considered as clinical endpoints. These parameters were assessed once again during 1 month follow-up after study recruitment. Study objectives. The primary objective of the study is to assess the correlation between STE at admission and LVEF prior to discharge. The secondary objectives were to assess the correlation between the STR percentage and LVEF and the correlation between both STE and STR with the 30-day mortality and 30-day major adverse cardiac events. Sample size calculation. A pilot study was done with 40 patients, 20 having anterior MI and 20 with inferior MI, and both the parameters of interest were thought to have a linear correlation. Hence, the Pearson's correlation coefficient was calculated to aid in sample size calculation. The correlation coefficient was negative 0.24 and negative 0.51 for anterior and inferior MI respectively. The necessary sample size with a two-sided alpha error of 0.05 and a beta error of 0.20 was 132 patients with anterior MI and 28 patients with inferior MI. Study approval and statistical analysis. Institutional Review Board approval was sought prior to the commencement of the study. All study variables were described using descriptive statistical methods. The continuous variables were compared using either independent two-sample t-test or a Mann-Whitney u-test as appropriate. The dichotomous variables were compared between the two groups using the chi-square or Fisher's exact test as appropriate. The results were analyzed using SPSS version 18. The results of the study: a total of 268 patients with a diagnosis of STEMI were assessed, of which 230 patients were finally enrolled. It's noted that very few patients belonged to CLIP class 3 and 4 put together, less than 10%, that's around 9.1%. Quick revision: CLIP class 1 includes individuals with no clinical signs of heart failure. CLIP class 2 includes individuals with rales or crackles in the lungs, an S3, and an elevated JVP. CLIP class 3 describes individuals with frank pulmonary edema, and CLIP class 4 describes individuals in cardiogenic shock or hypotension and having evidence of peripheral vasoconstriction, that is either oliguria, cyanosis, or sweating. So it's noted that all the patients who died prior to echo after recruitment in this study belong to CLIP class 3 and 4 at admission. This is a slide, this is a flowchart depicting the same. So initially 268 patients with STEMI were included in the study, of which 24 patients were excluded from the trial because they had either cardiac arrest or were not willing for revascularization, or had an unsure window period, or were thrombolized elsewhere, or having a new onset LBBB, or were not consenting for the study. So out of the 244 that were enrolled, again 13 were excluded because they either went discharged against medical advice or they had a death before the echo. For 231 patients, all the in-hospital variables were obtained, and one of the patient was excluded from the trial as there was no clinical or telephonic follow-up after 1 month. So the total number of patients for the final analysis is 230 patients. Here we have two tables depicting the baseline characteristics of the study participants with their categoric data on the left side and their continuous data represented on the right side. It's noted that 85% of the study population is male gender, which might lead to considerable errors in generalization of the study results to the general population. The type of MI is noted that a major portion of around 60% had an anterior wall type of MI, with the next common being infero-posterior and least being the inferior wall MI. It's noted that 47% of the study participants had diabetes, 42% had hypertension, and 46% had dyslipidemia, and 41% had some form of tobacco use. Next important thing to note that is the vast majority of the study population belong to either CLIP 1 or 2 classification, and having less than 10% of the study population representing the CLIP class 3 and 4. Which again leads to a difficulty in generalization of the study results to patients presenting with pulmonary edema. The mode of revascularization: 104 patients underwent primary PCI, 89% underwent thrombolysis. Rescue PCI was done in 22 patients, and 15 patients were managed conservatively with pharmacoinvasive PCI. The window period, it's to note that vast majority of the patients presented within 6 hours. There's more than half the study population presented within 6 hours of onset of index chest pain. Coming to analysis of the continuous data, it's noted that the mean age for presentation was around 56 years with a window period of around 6 hours, and the average hospital duration was 2 days, extending to 3 days. And the sum of ST elevation in millimeters for all patients, the mean was found to be 13 millimeters, 13.06 millimeters to be exact, with anterior MI having the maximum, that's 15.89 millimeters, and inferior posterior following with 9.66 millimeters, and least sum of ST elevation was seen with patients with inferior MI, that's 7.8 millimeters. Coming to the ST resolution percentage, it's noted that the mean in all patients was 55.3%, with maximum resolution being seen in inferior wall MI with 59.5% resolution, and the least resolution was seen with anterior MI of 50.9%. As mentioned in the previous slide, the mean STE among the study population was 13.06 millimeters, and mean STR percent was 55.3%. There was no statistical significant correlation between the window period and STE. However, the study found out that the STR percentage showed a mild inverse correlation with the window period, meaning a patient who presented earlier would have a higher STR percentage. The mean LVEF of the study population was 42.73 by a biplane Simpson's method and 42.8% by Thicol's method, and there was excellent correlation between these two methods. Patients with anterior MI also had a statistically significant lower LVEF than those with inferior and inferior posterior MI. It's also noted in the study that mitral regurgitation was more common among those with inferior and inferior posterior wall STEMI. Here we have the echocardiographic parameters of the study, and here I'd like to draw your attention to the fact that patients with anterior MI had a statistically significant lower ejection fraction as compared to those with inferior MI and inferior posterior MI. One of the important findings of this study is that there's a good inverse correlation between STE and the LVEF, and they found out that this correlation was better in patients with inferior MI as compared to those with anterior MI or inferior posterior MI. An STE of 15 millimeters had an odds ratio of 8.5 in predicting the LVEF of less than 35%. They also found out that there is a moderate correlation between the STR percent and LVEF, and that an STR of less than 52.75% had a odds ratio of 8.06 in predicting an LVEF of less than 35%. This is a graph depicting the correlation between the STE on the y-axis to LVEF on the x-axis. As we can see in this graph, there's an inverse linear correlation between STE and EF, implying that the slope is going downwards in a linear fashion. So using the mathematical formula y is equal to mx plus c, where y is the dependent variable LVEF and x is the independent variable, that is the STE, we are able to derive a formula to assess the LVEF just based on the STE. That is LVEF equal to 37.34 minus the STE divided by 0.567. It's important to note that we are getting a negative function instead of the positive one, as in the y is equal to mx plus c, because here we are having an inverse correlation between the two factors. In this slide, there are four ROC curves depicting the relationship between STE as well as STR against LVEF and 30-day MACE, major adverse cardiac events. Important to note here that the area under curve amongst these four graphs is highest for the ROC curve depicting STE against LVEF less than 35%. Another important thing to note here is that the specificity of the ROC curve depicting the relationship between STR as well as LVEF is highest amongst the four graphs, having 82% specificity. The strongest predictors of MACE and mortality at 30 days following STEMI were LV dysfunction on echo and Phillips classification greater than 3 at presentation. An STE of 15 mm is a good prognostic marker with odds ratio of 3.13 for MACE at 30 days and 6.54 for mortality at 30 days. An STR less than 52.75 also had a significantly increased risk for adverse outcome with an odds ratio of 3.17 for MACE and 5.67 for mortality at 30 days. This is a table depicting the odds ratio between different variables and 30 days MACE as well as 30-day mortality. As we can see that the statistically significant parameters are CULIP class greater than 3, STE greater than 15 mm, STR less than 52.75, and LVEF of less than 35%. The rest are not statistically significant. Discussion about the study. The majority of the patients in the study were male, resulting in a gross underrepresentation of the female patients, which might affect the generalizability of the study results to a standard population. Most of the patients in the study were relatively stable, having a CULIP classification class less than 3, which is similar to the CREATE registry having 85% CULIP class 1 and European registry having 90% CULIP class 1. Over 90% of the patients presented within 12-hour window period as opposed to 65% in CREATE registry. 45% of the patients underwent primary angioplasty and 16% in the study underwent pharmacoinvasive or rescue angioplasty. Owing to enhanced general awareness and increased health insurance coverage from government health insurance scheme, numerous patients could undergo primary angioplasty. There was no correlation between STE and window period. This is probably due to the fact that as window period increased, Q waves would appear on the ECG and STE may not increase further. There was also a good inverse correlation of 0.64 between STE at admission and LVEF, and this was consistent across all types of STEMI and was best amongst patients with inferior MI as expected in their pilot study. The ROC curves they suggested a cutoff point of 15 mm STE, which helps in predicting an LVEF of less than 35% with a sensitivity and specificity greater than 70%. An important aspect of this study was to derive of the formula which depicts the correlation between LVEF and STE. A major limitation of this formula is its applicability to a very limited range of STE that is most closer to the mean of the STE in the study, that is around 13 mm. Although this measurement of the LVEF based on STE is not very accurate, this could help in approximate estimation of the LVEF in a peripheral hospital where echo is not readily available. Another major drawback in this equation is the sole reliance on STE and not incorporating the other parameters, which could potentially influence the LVEF. For example, the window period, the type of MI. STR percentage was also found to have a good correlation with LVEF, and this trend persisted across all types of STEMI. The observed mortality at hospital discharge in this study population was only 2.6% and mortality at 1 month was 4.3%, which is significantly lesser than data from other registries. This observation could be because that most sick patients could not be recruited into the study. Limitations of this study. This was not a blinded study, which would have led to significant observer bias. The time delay between presentation and revascularization, that is door to needle time, was not studied, which could have affected the LVEF. The mortality rate was very less among the study participants, and therefore significant correlations could not be drawn to clinically meaningful hard endpoints, such as STE with mortality. The study population mostly consisted of stable patients with CULIP class 1. Therefore, its generalizability to the entire STEMI spectrum is doubtful. Another limitation is the fact that most of the study population is male predominant. Therefore, its generalizability to standard population is also doubtful. The formula to calculate LVEF from some STE would be valid only on a limited range of STE, that is around 13 mm. Various parameters were not included in studying the association between LVEF and STE. Although the presence of MR may result in underestimating the LV dysfunction, only 10 patients had significant MR in the study population, and hence it was assumed that it did not affect the study outcome. Conclusion: STE is a useful parameter on admission ECG in patients with STEMI. It has a good correlation with LVEF and the hospital outcome. STE cutoff of greater than 15 mm has a high odds ratio in predicting LVEF less than 35% and in predicting the 30-day MACE. STR percent post revascularization also has a good correlation to LVEF, and STR less than 52.75 has a good odds ratio in predicting LVEF less than 35% and in predicting 30-day MACE. In case of unavailability of echocardiogram, we can use the formula LVEF equal to 37.34 minus the sum STE divided by 0.567. Cross references. According to the authors of this study, similar articles which compare the STE and STR with LVEF and hospital outcome have not been found in both national and international journals. However, an article published in Revista Española de Cardiología in Spain found out that sum of STE is a predictor for microvascular obstruction in patients treated successfully by primary PCI. An article published in Circulation, a journal by AHA, found out that the early STR percentage is a good prognostic factor for acute STMI. Take home messages from this study and article: the STE is a useful parameter on admission ECG in patients with STEMI, and in case of a non-availability of 2D echo, for example, a patient presenting to our casualty at 9 time with STEMI, we can use the following formula, that is LVEF equal to 37.34 minus the sum STE divided by 0.567 to get the approximate LVEF. An STE cutoff of greater than 15 millimeters is a good indicator that the LVEF is less than 35%. Thank you for your time and attention.